Okay, so it's 7:02, so I think I'll begin. Welcome back, everybody, to the part two of the fourth annual Montreal Oscillometry Summer Seminar. Just a few housekeeping points. Try and keep your microphones off as much as possible. If you want to make a comment, using the space bar will transiently turn it on. Keep your video off if you don't mind as well, in case there are people who have limited bandwidth, and this may make a difference for them. And finally, we will try fielding some questions from the audience at large via chat. So Stuart is going to be helping with that in his co-hosting responsibilities. So we'll start with the discussants leading off the questions, and then add a few more questions from the audience. The host has asked me to start sharing my video. I'm not sure what that means. So whatever it is, I guess start sharing my video. Let's see what happens. Okay, so a little bit more on statistics. If we look at the 2018 seminar, we had 30 attendees, 2019, 60, and this year we had 125 signed up, of which 105 signed in 2 weeks ago. For today's broadcast or seminar, we have 135 signed up, 38 institutions, 16 corporations, and 16 countries are all recommended. So despite the online attendance, we still have an empty auditorium, but we are making do under the circumstances. Last week, we really had great talks. Stellar tribute to Arthur Dubois by Charlie from University of Vermont, and urged by the discussant, Jeff Fredberg from Boston, to write it up. And I hope Charlie will take it to heart, because I think it was just a great resume of an inspiring life in terms of research and just both as a person. Zoli gave a thorough review of oscillometry, and in typical Zoltan style, was minimizing the importance of what he was doing by characterizing it as just some thoughts. But really, I think he made some important points, which likely will be echoed today, I think, by the talk that David is going to be giving us later on, and a nice discussion by Brody, also from Boston. And then Jason had the audacity to take a lot of us clinician types into the mathematical world, where a lot of you other fellows and ladies are quite comfortable with. I know for me, this is a little bit a shaky ground, and Jason underscored the fact that we, although we think we know what we're doing, we all in fact live in a world of fiction. So it was nice to be put in that place. Putting wonderful images to the function of structure function was the talk by Sarah and Dante, and just spectacular work that they do, and Raul giving his comments on that imaging. And then finally, we had what I call the new kid on the block, the oscillometer from Cognita Labs, and their daring entry into the clinical arena by presenting data from COVID-19 subjects, which was of obvious interest to us. Also, Rajoshi, thank you very much for that presentation. The sessions are being recorded, provided the presenter does not object, so I will edit out from recordings anybody's talk who they would feel more comfortable waiting until it was published, or if ever. But those that will remain in the series can be accessed at a temporary refuge we've been given. So the REG, for Respiratory Effectiveness Group, if you Google the Technologies Working Group of the REG, you will get to the page that you see on your right. The Respiratory Effectiveness Group is an international think tank that marries academia and industry, based in Cambridge and Singapore simultaneously. We get together 3 times a year somewhere in the world and delude ourselves into thinking that we actually are going to change the way respiratory disease is practiced. Whether or not that happens, we'll see, but nonetheless, we have a very good time dreaming about the world as we see it. The turquoise link halfway down that page, the rectangular turquoise box, if you click on that, you'll get the recording from last week's or 2 weeks ago's seminar, and the subsequent seminars will be added to that site until we have our own home. Speaking of our own home, I'm happy to say that we have raised funds that will probably be sufficient for the construction of a website, and we're well on our way to obtaining enough funds to allow transcription and submission for publication as a proceedings. The talks, should the authors be willing to do so. Thank you very much to our industry partners, both in terms of equipment and pharmaceuticals. You've really risen to the occasion nicely. I would urge the other industry partners in the audience to look at the slide and realize there are still spaces for their names if they would be willing to contribute, and I hope this slide will be more crowded in 2 weeks. So for today's session, we're going to be starting off with a talk about oscillation mechanics in the homeless population of Ottawa by Carly DeSinton from Ottawa, and Chung Wei Chow will give her perspective on that. David is going to be talking about oscillometry in small airways disease, and I have a funny feeling he will be echoing some of Zoltan's issues that despite we thinking we know what we're measuring, we probably don't, or as unfortunately is the case, even in good journals, we still see a lot of fuzzy thinking about the oscillation mechanics parameters. So hopefully David will clarify that, help us get our thoughts in order. And Jeff, if he's able to link in from rural Nova Scotia or New Brunswick, I'm not sure where his cottage is, will be making some comments and leading the discussion. Peter Savagev, who's in the radiology department here at McGill, has been foraging around in my practice, looking at my CAT scans for the past couple of years, and he may have found, or he thinks he's found, a new CT metric. We'll see how that presentation goes, your reactions, and to comment as to whether Peter and I are delusional or not will be Raul again from Boston, who's one of the wizards behind quantitative CAT scan software, amongst other things. Finally, we have, not finally, we still have two more. Rachel Eddy, who is now relocated to University of British Columbia from the group at Western, the Robarts, will be talking about pulmonary imaging and giving us a case presentation that will marry imaging, oscillation mechanics with an unfortunate victim of vaping. And Alex Bell, who I think is math from Oxford, trained in Leicester with Salman Siddiqui, and now is in Michigan, and I apologize for having put him at the University of Chicago in an earlier version of the program. We'll lead the discussion. And then finally, we have yet another new oscillation device. Stefano Paganini from Northern Italy will be talking about their equine oscillometer. And we have another veterinarian from Italy, Michela Bologna, who will be leading the discussion on that. So I think I've probably taken up my 7 minutes plus, so we can move on to the presentations themselves. Just a preview of what's to come. In 2 weeks' time will be a potpourri of various oscillation mechanics topics to be announced. In a month, we will have a session that will look at the COVID ventilators from Burlington, Barcelona, and Brussels. And hopefully in the second hour of that session, we can put together some sort of panel discussion on pulmonary function testing in general in the COVID era. So that's it for my spiel. Okay, David, you're on.
Okay. Share. Oh, I got it. Okay, hope everybody can see this. Let me move. All right. Okay, so I hope everybody can see the screen. So I'm Dave Tasca. I'm a critical care anesthesiologist and biomedical engineer from the University of Iowa. And forced oscillations is something I've been dealing with since grad school in the early to mid 90s, and Ken Luchin's lab. So I've worked with Ken and Bella Suki, and I obviously very familiar with many of the faces I'm seeing on the Zoom meeting. I have the following disclosures. One which might be relevant is I'm a founder and CEO of a very small ventilator company called Oscillometry, which has some STTR funding. Despite the name, there's not a whole lot that's relevant to forced oscillations in terms of diagnosis, but more related to therapy for acute respiratory failure. So let me talk about what really motivated my interest in this, because when I cut my teeth on forced oscillations in the 90s, I was dealing with a very different frequency range than what kind of transpired in the early to mid 2000s. And that was a range surrounding breathing frequencies, which is very difficult to obtain in awake subjects, particularly patients with asthma or COPD. So I was very interested in the sensitivity and the specificity of forced oscillations over the more commonly used frequency range, 5 to 32 hertz or so, in detecting small airway disease or small airway obstruction. So I'm going to show some data with computational modeling that my lab has been developing over the years. And the motivating question here is does oscillometry permit inference on the locus and or distribution of airway disease? I'm not a pulmonologist, but I'm frequently asked by directors of PFT labs about oscillometry, certainly in regard to preoperative testing, especially thoracic patients that may be undergoing lobectomies or interventional pulmonology. And I'll say, as far as the advantages go, it's very sensitive to mechanical derangements in lung function. I can't deny that. It does give you very unique insight into structure-function relationships, especially if it's used in conjunction with different imaging modalities, computed tomography, magnetic resonance, or even electrical impedance tomography. And of course, I can't deny some situations, it's great because it requires minimal cooperation of the subject. If they can breathe and they can hold their cheeks, then there's potential to get some very interesting data. So that makes it ideal for use in pediatric and neonatal patients, and then certainly in critically ill patients who may be intubated and sedated. But I have to acknowledge disadvantages of oscillometry. It's technically and mathematically very sophisticated, both in terms of instrumentation and signal processing. I'm going to put forward that it lacks specificity with regard to disease, not just diseases like asthma, COPD, central airway obstruction, but also the locus of airway disease. Has very high measurement variability. So whereas standard spirometry, I think the variability is somewhere in the order of 5%. With oscillometry, we're looking at about 15 to 20% variability, depending on glottal artifacts and chest wall tone and lung volumes and things like that. And I'll also put forward that it's very difficult to interpret in the presence of what I call complex physiologic processes. These are very nonlinear processes that deviate from the assumptions of forced oscillations, where you have an assumed linear time invariant system. So these would be things like flow limitation, either inspiratory during airway obstruction, say in CPAP studies, or expiratory flow limitation, dynamic airway compression, and then intratidal processes like recruitment and de-recruitment and parenchymal overdistension, which you can see in patients with ARDS who are undergoing mechanical ventilation. So if we take a look at a typical impedance spectra over the frequency range that I discussed, here's a healthy graduate student that was in Ken Luchin's lab, probably in 93, 94, for all I know, it could be my data. And some features that you're going to see here, I'm expressing this as resistance and reactance as a function of frequency. The resistance, or the real part of impedance, essentially constant with frequency, we all know. Here's the reactance, starts off as negative at low frequencies, crosses zero, what we call the resonant frequency, and then shoots off to higher values, positive values. This is the same data, I've just changed the scale to compare with a patient with chronic obstructive pulmonary disease. And there's some features that you can see, obviously. The magnitudes of the resistance and the reactance are much higher compared to the healthy case. And there's this frequency dependence that we see in the real part of the impedance. Now, I would say probably early to mid 2000s, certain indices related to these impedance spectra have popped up in the literature. One being the R5, the resistance at 5 hertz, which is purported to represent the resistance of all the airways in the airway tree. And R20, resistance at 20 hertz, is supposedly the resistance of the central airways. And the difference between R5 and R20 would be the resistance, hopefully, of the peripheral airways, or perhaps reflective of the heterogeneity of airway obstruction. X5, the reactance at 5 hertz, we think mostly is related to the elastic recoil of the lungs and the chest wall. The resonant frequency, of course, where the reactance crosses 0. This is the transition frequency from elastic recoil to gas inertia. So right at the resonant frequency, you have the ideal transfer of energy between potential energy and elastic storage and kinetic energy and the gas column that's oscillating back and forth in the central airways. And then finally, an index that I could never get my mind around. I don't know why this is popped up in the literature, this area under the reactance curve that Jason very elegantly derived a mathematical expression for, assuming a single compartment model 2 weeks ago. And this is thought to reflect peripheral airway obstruction. So, but certainly it's going to depend on what the low frequency reactance point would be, and it's measured to the point where the reactance crosses 0. So dependent on the lowest frequency that you're using as well as the resonant frequency. Well, here's some reported oscillometric indices and some common lung diseases. This is not a comprehensive literature review. I've kind of cherry picked out representative healthy studies, asthma, COPD, cystic fibrosis, and chronic airway obstruction. I'm reporting the resistive indices, R5, R20, and the difference between the two, the low frequency reactance, resonant frequency, and area under the curve. And you can see in comparison to the healthy, and I didn't do statistical analyses on these, I just want you to see the trends. Certainly all the resistive indices are higher compared to a healthy condition. The X5 gives a lower or more negative value for the reactance. The resonant frequency, which is anywhere between 8 and 12 hertz or so in healthy subjects, is shifted to higher frequencies. And the area under the reactance curve is certainly much higher compared to healthy subjects. So do these numbers actually reflect the locus of airway obstruction? Well, to answer that question, very simple analysis with a computational lung model in collaboration with Marin Taufai, the University of Auckland. And we took a prototypical 70 kilogram healthy adult male volumetric CT scan, and we segmented out the central airway tree and the pleural surface. And with Marin's base filling algorithm, we developed an airway tree which consists of over 60,000 cylindrical airway segments, over 30,000 terminal bronchi, and over 30,000 viscoelastic acini. The airway segments are assumed to have distributions of cartilage, and they're distensible, more distensible down at the periphery than they are in proximal airways. And the total dead space of this model is about 150 cc. So this is a way that we can compute the effective impedance of the model just by adding up all the appropriate impedances of the tissue elements and the airway elements in series and parallel. Now this model has a distribution of airway diameters that I'm showing here. Diameters, all the way up to about 16 millimeters. This is the distribution curve. And I'm dividing this tree up into what I call small airways, which are those airways below 2 millimeters, and then proximal airways, which are above 2 millimeters. But I'm going to look at proximal airways that are greater than 2 millimeters, but have less than 10% cartilage. So 3 distinct simulations I'm performing here. One with constricting small airways only, both uniformly and heterogeneously. Proximal airways only, greater than 2 millimeters and less than 10% cartilage. And then I'm going to constrict both the small and the proximal airway segments. So computing the impedance spectra and then taking a look at these resistive and reactive indices, this is the following behavior that I'm seeing when I only look at airways, constricting airways less than 2 millimeters. So these are the indices, and what I'm showing on the x-axis is the percent diameter reduction. This is entirely homogeneous airway constriction, airway obstruction. And you can see, yeah, certainly all these indices, the resistive indices, have a tendency to reach a peak as you constrict the airways. For R5, and the difference between the two, this peak occurs at about 70% diameter reduction, and the peak is not as pronounced for R20, and it occurs probably at 50% diameter reduction. If you take a look at X5, relatively constant till about 40% diameter reduction, and then it kind of falls off and becomes much more negative. You may infer that could be due to increased tissue stiffness, but remember, I'm only affecting the airway caliber here. The resonant frequency is a tendency to be shifted to higher frequencies, and of course, the area under the curve, after about 40% reduction in the proximal or peripheral airways, you'll see this kind of shoot off to much higher values. Now, if I look at only the proximal airways, all right, so above 2 millimeters, but less than 10% cartilage, qualitatively very similar behavior. Certainly, I've shifted these peaks to higher degrees of constriction, but there's not a whole lot of difference here. And if I constrict not the whole tree, but what I've defined as the proximal and the small airways, again, qualitatively, very similar differences here. All right, so I put forward that these indices, R5, R20, and area under the reactance curve are very nonspecific with regard to the locus of airway obstruction. Now, if I take a look at heterogeneous peripheral airway obstruction, what I've done here is take the same model. I induce a certain average constriction in the central and proximal airways, but in two of the cases, I have wide distributions of variation. So standard deviation of 25% in one case and 50% in the other. And of course, I'm going to compare that to the uniformly constricted case. So these are the results for heterogeneous airway constriction, and you can see this mirrors what I showed in the previous slide for all the airways being constricted. But if I constrict it, and what I'm showing now on the x-axis would be the average level of airway constriction, but with a 25% heterogeneity, I'm seeing, again, qualitatively very similar behavior in the resistive indices and the reactive indices as well. And if I look at the greatest degree of heterogeneity in the periphery, what do I see? If anything, these curves are starting to become flattened out. So the index of R5 minus R20, which is thought to reflect the heterogeneity of peripheral airway obstruction, actually appears to be less sensitive to higher degrees of heterogeneity compared to these other cases. Now, if we take a look at real data, and I'm looking at within subject effects of particular interventions, this is, again, data report in the literature, an asthma study in the Wilcock group that I reanalyzed the data a little bit to account for differences in the male and female population. But this is pre and post bronchodilator. And you can see all the resistive indices will decrease after a bronchodilator. The X5, the low frequency reactance, actually becomes positive. Resonant frequency is shifted to lower frequencies, and the area under the curve is also reduced. Chronic obstructive pulmonary disease, in this study, they compared inspiration versus expiratory values. So presumably during expiration, there's going to be some dynamic airway compression, certainly going to be an increase in resistive properties during exhalation. And you can see all these numbers going from inspiration to expiration will increase, all right? And there's nothing particularly sensitive about the R5 versus the R20 or the difference between the two. Now, this is a very interesting study from Japan, chronic central airway obstruction. So these were patients that had tracheal stenoses, bronchogenic carcinomas that would be in the right or left main stem or in the carina. So you can't get much more specific with regard to the locus of airway obstruction with these patients. And this is before any kind of intervention or after an intervention with an interventional pulmonologist that would either stent the airways open or do some tumor debulking. And again, you can see all of these resistive indices will significantly decrease. So what can we say about these indices? Well, certainly increases in R5 and R20 will reflect increased airway resistance, but I'll put forward, they can provide you no information on proximal versus small airway obstruction. The difference between the two, it's certainly going to reflect increased small airway resistance. I can't really say based on these modeling results whether or not it's going to reflect increased airway heterogeneity. As the slide I showed you demonstrates, more heterogeneity, if anything, the difference between R5 and R20 is reduced. Decrease in X5 or becoming more negative would reflect reduced compliance or increased tissue stiffness. But in the simulations I ran, I did not change the tissue properties in the model whatsoever. I only changed airway properties. And as you saw, we do see changes, substantial changes in this X5 value just with peripheral, central, and total airway constriction. Increases in the resonant frequency being shifted off to the right or increases in the area under the curve. Yeah, that may reflect increased compliance, but it could also reflect changes in the inertial properties, which you'd expect to see if you're constricting the airways as well. So, so my own thoughts. I think oscillometry, at least over the frequency range that's commonly measured now, is exquisitely sensitive to structural and functional derangements of the respiratory system, but it lacks specificity with regard to disease diagnosis. And you saw that asthma versus COPD versus central airway obstruction. It lacks specificity with regard to moderate levels of airway obstruction and the locus of airway obstruction as well. But I admit it does have utility for within patient monitoring of disease progression or the response to treatment protocols, whether that's bronchodilation, whether it's lung reduction surgery, whether it's tumor debulking and stenting of central airway stenoses. So just would like to acknowledge my former grad student, Jake Herman, who helped me with many of these simulations, and of course, Marin at University of Auckland for helping me develop the model and my funding sources. So I'm happy to take any questions at that point.
Yeah, Dave, this is Jason Bates. Can I ask a question?
Sure.
Yeah, a terrific talk. Really very elegant.
Sure, Jason.
And the conclusions you come to don't actually surprise me, but I think you demonstrated them really well. There's a, in your modeling, did you have an upper airway compliance, I mean, related to the cheeks and the equipment? Yes.
No, and that's a good point. So I made these measurements assuming you had access to pressure and flow right at the trachea. So right. You could make an argument that I wouldn't say the study's flawed, but maybe perhaps the results I'm seeing are actually cleaner than what you would get in a real subject, or had I tried to model the nasopharynx, the oropharynx with compliant cheeks and a compliant tongue. But all this is subglottic simulation.
I certainly wasn't suggesting the study was flawed, not in the least. But I'm just with that extra proximal compliance, you have the potential for central airway shunting, which can actually add to the frequency dependence of resistance of that over that sort of 5 to 20 hertz range.
Yeah, yeah, like the meat effect. Absolutely, yeah, I agree with that. Yeah.
Thanks, Dave and Jason. That was great. I want to add to those points. This is Jeff Maxim on vacation in rural Nova Scotia, as Ron pointed out. Am I coming through clear?
Oh, yeah, I can hear you.
Oh, great, great. Yeah, I think Jason raised a very important point, and to put it into perspective, he showed 2 weeks ago that with a very simple model of heterogeneity, but including or not including the upper airway shunting effect, that with mild heterogeneity or mild in the only the two peripheral airways that were in the Otis model, so that's simply the two balloon type models, that you can get R5 minus R20 is dominated by central airway shunting. But however, with severe peripheral airway narrowing and, if I recall correctly, heterogeneity, you did see that R5 and minus R20 was in part reflected with the small airway narrowing, with the simplest of models. But what you're showing up very elegantly in the more complex model is that it is very insensitive to that. And the other indices, namely X5 and area under the curve, if you were to pick amongst them, you'd pick that as reflective of peripheral airways. And it reminds me of the way the literature in oscillometry grows. We started dominated by looking at the resistance, and you could see many curves showing different severities of asthma or COPD, and resistance indeed being reflective of obstruction. Meanwhile, the reactance was changing even more, but the papers refused or neglected to discuss this apparent data that was in the papers as being reflective of peripheral airway obstruction, because it's a confusing measure, reactance, imaginary part. Now we're becoming more comfortable with reactance, but we've shifted to this R5 minus R20 as being the best measure for peripheral airway obstructive. And I think we're not looking at the whole of our data, and shunt may be the more dominant factor, which changes R5 minus R20 in many of our mild patients, perhaps not the severe, as Jason showed, but reactance might actually be a more solid measure to rely on. What are your thoughts?
So yeah, I agree with the R5, R20. There is shunting that's going on in this model. It's just not occurring in supraglottic structures. It can, but I have distensible airway walls. So, you know, if the peripheral constriction is high enough, there's going to be some shunting in the central airway walls. So that would be certainly consistent. But I agree with you. I think for high degrees of airway constriction, these reactive indices, I think, I'll say they're more specific, but they're potentially more sensitive than the resistive indices. Because if you take a look at where these changes are occurring, it's for degrees of constriction in the periphery or even in the more central proximal airways of 40% or more, which is pretty substantial. So you know,
I think would mirror some of the ventilation heterogeneity images. We do see very significant obstruction in patients, blocking off significantly larger parts of the lung than I anticipated.
I think the real kicker is this central airway obstruction data, because you can't get much more specific than obstruction in the trachea or the main stem bronchi. This is by definition, this is central airway obstruction. Now, was there some inflammation down in the periphery? And you know, when they made these measurements, you know, a week or two after a tumor debulking or a stent deployment, did you change the peripheral airway properties? I don't know, but I mean, all of these indices are going in the same direction after the central airway obstruction is relieved.
Hello, David. May I speak?
Can I?
May I ask a question? This is Sam Bayat from France.
How you doing?
Hello. Yeah, thanks. Yeah, this is a very, very elegant study, and as the modeling, especially, is nicely done. Yeah, I was wondering whether, because several years back we had compared indices that were obtained from the lung impedance measurements through the constant phase model. and we compared it to regional lung ventilation measured with xenon. And there we found that, in a heterogeneous lung, that the regional peripheral airway heterogeneity was really nicely correlated to lung elastance when it was obtained from a model fit of the impedance data. I was wondering if you've used indices rather obtained from modeling rather than the R5 minus R20.
So you're talking about inverse modeling, and I've certainly read many of your studies, and I assume the data you obtained was in rabbits, and I don't know the frequency range that you used for the constant phase model. But I question the utility of applying the constant phase model to this data. This is human data, and I think to get very robust estimates of G and H and eta in the constant phase model, you need to be down at much lower frequencies. At least in adult humans, you got to be 1 hertz or below. I mean, you need that kind of a bandwidth, which this data didn't have. So I didn't do any kind of an inverse model analysis with the forward model predictions. But I've looked at this before, and yeah, certainly many of the other parameters like G and H and eta can be artifactually influenced by heterogeneous airway constriction, but at much lower frequencies than what I simulated here.
David, this is Charlie Irvin. I wanted to ask a question. The group in Sydney, led by Greg King, has shown pretty nicely that X5 and reactance is highly dependent on lung volume. So one of the problems with this technique in general, and I'm wondering about your simulations, is not taking into account the changes in lung volume and their subsequent effects on clearly the amount of oscillatory volume, which is going to change reactance, but also going to change resistance.
Yeah.
So I agree with you that the central obstruction data is, as you say, is kind of hard to work yourself around, but what about the rest of it?
Yeah, so these simulations were done when we scanned this subject. It was a total lung capacity, and then we scaled the airways down to what we think would be functional residual capacity. So lung volume was constant, and these were completely linear simulations. But I absolutely agree with you. X5 is going to change. Higher lung volumes, I'd expect to see more strain stiffening in the parenchyma, and that would decrease compliance or increase elastance. So I absolutely agree with that. There could be some recruitment if you're at a volume above subject's closing volume, and that's going to decrease elastance or increase compliance. So I think X5 would be very sensitive to changes in lung volume. Absolutely.
And certainly in the degrees of airway narrowing that you're getting, you're going to, and if there's any liquid in an airway, it's going to close.
It'll close off. Yeah. Yeah, absolutely. Yeah. Yeah.
Dave, can I make a comment? Just to return to Jason's comment very briefly. So I would happily sacrifice 6,000 of your segments and add to the rest of 400 just one single viscoelastic unit in parallel with the whole stuff. So I think one part of the model is overly detailed, and the fundamental component is missing. This is basically what Jason referred to.
Which component's missing? Viscoelasticity?
The central airway, central airway shunt in particular the cheeks. Yes.
Yeah, up here. Yeah. And I agree. And that's extremely complicated anatomy with supraglottal structures, oropharynx, nasopharynx. Absolutely agree. And I don't know what the effect would be, but if anything, I think it's going to obscure these results even more, because I think if you're able to make the measurements, in theory, make subglottal measurements of impedance, it's not going to be much cleaner than that. So if anything, I think if I included a compliant upper airway structure, these indices are going to be even less specific. I don't know if that answered your question.
I don't know if it's my responsibility to cut things off in essence of time. Ron, maybe you could clarify. Are there time for more questions or?
I think we should move on at this point. That was a great talk. Thank you very much, David. And I hope the discussion, which is not completed clearly, can happen offline, or maybe at one of the future seminars, we'll just have an open hour where we can revisit some of these issues. So
Yeah,
thanks.
people have questions. I think Ron put my email out there, so yeah, I'm happy to talk offline too.
Okay, great. Thanks again. So I think at this point, I'll turn the floor and the screen over to Peter Savage, who is going to tell us about his new QCT metric, the mean curvature of isophots. So over to you, Peter. Thank you.
Hello. So my name is Peter Savage, and unlike many of you, I'm actually a computer scientist by training. So I'm not a physician or a radiologist. So my talk will have a little bit of a computer science flavor to it. My main affiliation is with the Department of Radiology at McGill, but I'm also affiliated with the School of Computer Science and the Medical Physics Unit at McGill as well. This work is done in collaboration with Ron, actually, and I actually presented a very preliminary version of this work at last year's seminar. And at the time I didn't have many results, and instead I put the emphasis on the methods. And so because of that, I quickly lost the clinical audience among you. So learning from my mistakes, this year I decided to structure my talk a little bit differently. After a brief overview, I will go straight to the results in order to show what the method can do and hopefully catch your interest. And only after that, time permitting, I will get into the image analysis technicalities for those of you who are interested in that. Okay. So as the title of my talk says, so this is about quantitative CT analysis for the detection of COPD in chest CT scans. We introduce new measures based on the concept of mean curvature of isophots, and we compare them to standard QCT measures and also to deep learning. Okay. So what is MCI? It is a concept that is well known and long used in computer vision to capture important geometrical information in images, whether they are actually medical images or natural photographs. So it is a very general kind of idea in image analysis. And for our purposes, you can think of it as essentially producing an image transformation which takes chest CT as input and creates another image as output, which I call the MCI geometry image. And then from this geometry image, we can compute simple features, image-derived features, and compare them to standard QCT measures as well as to deep learning. And so this is what this transformation looks like. On the left, you see a slice through a chest CT scan, and on the right, you see a slice. You see the corresponding slice through the corresponding MCI image for this scan. And of course, you can mask out the lungs, and you can focus your analysis on the lung voxels only. Okay, and you can transfer that mask to the MCI image to limit your analysis to the same voxels there. So the idea is that standard QCT metrics are usually defined on the histograms of voxel intensities, also known as Hounsfield units of the chest CT. And so in a similar way, we can define measures on the histogram of voxel intensities of the MCI image. Okay. So I'm going to give them obscure names for now, MCI 1.1, MCI 1.3, and I'll explain them later once we get to that point. Okay. But the basic idea is that it's simply that instead of working with the voxels of the image on the left, instead we're going to work with the voxels on the image on the right. Okay, so the overall contributions of this method are that we hope to demonstrate that it correlates with several spirometry and oscillometry derived measures. Unlike standard quantity CT metrics, these correlations hold specifically at the early stage of COPD. Our technique performs well at discriminating early stage COPD as well as non-gold COPD, also known as gold zero, from normal controls. Furthermore, our technique performs comparable to or even better than convolutional neural networks for discriminating normal controls from COPD patients. And so with, at least in our opinion, our technique performs well on a small and heterogeneous data set, okay? So with that in mind, let's go right away onto the results. And first, let's look at the population characteristics. So these are all subjects taken from Ron's practice, okay? So we work with a total of 274 patients scanned at seven different institutions, although the vast majority of them have been scanned at one institution, but a significant number of patients have been scanned elsewhere, okay? There's different scanner manufacturers and models that are presented in this data set. There's a lot of numbers in this table. I just would like you to focus on the top row here that shows the distribution of subjects across gold stages. So as I said, we have 274 subjects that are approximately equally distributed across gold stages, except for gold 2, which takes the majority of subjects. But outside of that, we have about 30 controls, 30 gold 0 patients, and 48 gold 1, 44 gold 3, and a few gold 4 patients. Coming from Ron's practice, this population is very well characterized with many measurements on lung volume, diffusing capacity, and airway resistance, as well as oscillometry. Although not all subjects have oscillometry measures, only a subset of 210 of them have oscillometry out of 274. Okay, so I will next move on to speaking about the discrimination between healthy controls and COPD subjects at different gold stages. So this is what the distribution of the MCI-11 variable looks like as a function of gold stage. So what we'd like to quantify here is the discrimination between different groups based on different gold stages based on this measure to determine its performance as a diagnostic test. And specifically, we're going to look at discrimination between or separability between our controls and gold 0 patients. Here, controls and gold 0. We're also going to look at the separability between controls and a group which I called early COPD, which consists of gold 1 and gold 2 patients grouped together. And finally, the separation between controls and more advanced COPD disease, grouping subjects in gold 3 and gold 4 stages. We will compare these two standard quantitative CT measurements, such as LAA, which is simply the fraction of lung voxels that have a value of less than negative 950 Hausfield units, as well as with LD, which stands for lung density, which is simply the 15th percentile of the lung density histogram. So even as you're looking at these plots, maybe you can visually appreciate that, for instance, with LD here, but also with LAA, there's very little visual separation between controls and gold 0, for instance, and even a lot of subjects at the early gold stage. Whereas with this MCI measure, the separation seems to be a little bit better. So we actually have quantitative measures to show for this. And so I show here for each measure the balanced accuracy, the sensitivity, specificity, and precision macro values for comparing controls to gold 0 in the left column, controls to early COPD, meaning gold 1 and 2 in the middle column, and controls to advanced COPD, meaning gold 3 and 4 in the right-hand side column, okay? Balanced accuracy has been shown to be a better and more reliable measure than the usual test accuracy when the data set is unbalanced, meaning when there's a lot more subjects in one group than in the other. And it's defined simply as the mean between the sensitivity and the sensitivity. Specificity and sensitivity. As for the precision macro, it is basically the mean per class precision value. which in the case of binary classification amounts to simply the average between the negative predictive value and the positive predictive value. Furthermore, for a binary classification experiment, balanced accuracy is also equivalent to the recall macro, which is simply the per class average of the recall values. Anyway, so here we compare the MCI measure on the left to LAA, lung density, as well as this measure D here, which I'm going to explain on the next slide. What I would like you to see here as a take-home message is that when it comes to gold zero specifically, the MCI measure performs far better than any of the other measures. And as we move towards more advanced goal stages, and not surprisingly, the standard quantitative CT measures improve as well in terms of accuracy and every other measure. As for this measure D here, it did not perform quite well. So let me just say a few words of what it stands for. What does it mean? It is simply it's a parameter derived from a power law for the distribution of low attenuation clusters in CT imaging, in COPD. So this concept was introduced about 20 years ago in the context of two-dimensional CT imaging of the lungs in this paper here. More recently, the same idea has been explored in 3 dimensions. And in all these studies, it has been shown to have some diagnostic value, especially in 2D. The 3D case is a little bit more up to debate. But in our data set, it did not really perform particularly well, as you can see here. Okay, so this was what we saw so far was the discrimination between healthy controls and COPD subjects grouped based on the gold staging. Now we're going to look at the simple binary discrimination between controls and all COPD subjects regardless of gold stage. And so these are the results. So again, we see on the top row, we look at the balanced accuracy, which is the same as the recall macro value, the sensitivity, specificity, and the precision macro value. You can see that for each of these performance measures, the maximum values are reached with the MCI measure here on the right-hand side. And so in particular, we do obtain about 85% of balanced accuracy for the detection of COPD. And we compared these results to deep learning. I'm sure all of you have heard of deep learning as this sort of amazing AI technology, which is going to solve all of our problems. And there has been recent literature on using deep learning to detect COPD in chest CT scans. So we just want to see how our method compares to deep learning. So very briefly, a few technical details for those of you who are a little bit more familiar with deep learning. So we used a convolutional neural network, which is very popular in the literature. It's called ResNet 50 because it has 50 layers. So it's a fairly deep network. It's a common, as I said, it's a common use network. We used, as it is common in this domain, we used data augmentation in order to obtain an augmented and balanced set of 2000 scans in each category, healthy as well as COPD. From each one of these scans, we extracted 11 axial slices. We input them separately to the network, and the network classified them independently as being either healthy or COPD. And then we use majority voting across these 11 slices to come up with an overall classification for a given scan.
Can you wrap it up in about 2 minutes because we're running a little bit over time?
Sure. So these are the results. In the left column, we see the accuracy result of applying this deep learning method on the CT image data, which is about 76. There's substantial boost in performance when we apply deep learning, not on the CT images, but actually on the MCI images. And just to compare with published literature on deep learning and COPD detection, our balanced accuracy compares it's very similar to published values in this paper that came out in 2018. And our recall macro and precision macro are very similar to values published just this year in 2020. Even though both of these studies used much larger and prospectively acquired data sets with much more advanced preprocessing than ours. Finally, just want to quickly say a few notes about correlation of these metrics with spirometry and oscillometry measures. So this table shows correlation with spirometry values. I apologize for the large amount of numbers, but if you look on the left-hand side, we see the first 4 columns are the correlations for the quantitative measures we're looking at over the entire set of subjects that we have. For each entry, we'll see the Spearman rho value, and we see the corresponding p-value. So in the top here, for instance, the p-value is all 0. That means the correlation is very significant across the entire population for each of these imaging features. I need to say that these p-values are actually adjusted for multiple comparisons. So you can actually take them at face value, okay? Bottom line is the following: over the entire population, everything correlates very well, all with essentially all the spirometry measures we have, okay? But when we divide subjects in 3 tertiles in terms of disease severity as defined by the ratio of FEV1 over FVC, what we observe is that in the early disease tertile, which is tertile number 1, MCI3, which is one of our 2 measures, is the one which correlates by far the best with spirometry. So it has a significant correlations with 8 spirometry variables, whereas the standard quantitative CT measurements of LA and LD only have a few. But as you move towards the more severe spectrum of disease, then the MCI measurements stop correlate, whereas the standard measurements start to correlate. This is with spirometry. This is now with oscillometry. So same idea. All the imaging features we have correlate very well with almost all of the oscillometry variables over the entire population. But when you break down the population in terms of disease severity, in the early disease group, the MCI measures outperforms by far all the others. And then as we move towards higher severity, then we start to see a better performance by the standard quantitative CT measure. So to conclude, I'm literally going to repeat the slide I showed before, where we present a technique that correlates well with several spirometry and oscillometry measures, specifically at the early stage of COPD. It performs well discriminating early stage COPD and non-gold COPD from controls. It's comparable to or performs better than the convolutional neural network for discriminating normal controls from COPD patients. And I had some slides on the methods, but sounds like we won't have time for those. So I'm happy to discuss offline further if you have any questions.
Great, Peter, thank you very much. I'll turn the floor over to Raul, and Raul will ask you maybe just to do a comment or 2 yourself, and then in the interest of time, we'll let any questions from the floor be addressed to Peter directly via email.
Okay, yeah, thank you, Ron. Thank you, Peter. I mean, this is a very interesting talk. Clearly, we are limited by some of the quantitative metrics on the early phases of disease. I think you clearly effectively show that this is kind of a new technique or a new metric to quantify potentially early smoking-related injury. I mean, I wouldn't dare to call it still early COPD in the gold zero. Maybe still might be a little bit of an open-ended question, but clearly you are able to capture, in my opinion, early changes relating to a smoking injury that might resolve into COPD, no? And how that resolves maybe something to further evaluate. But yeah, very, very interesting in that regard, because I don't think we have anything like that. I guess my second thought, now that you, I think, establish this clear evidence that there is only a power to discriminate this early injury that could potentially resolve into COPD, therefore having a strong, then will have a very powerful, I think, utilization. I guess the second question is, what is the endophenotype this technique is tracking, no? I mean, if only there is that can lead to some interesting hypotheses, formulation, questions. So I wonder, and just I leave it like that, taking into account that you are basically tracking tracking curvature of these sort of isolines. I wonder if really what you are tracking are changes in the vasculature.
So actually, I had a, if you wrote, thanks for comments. I actually had a slide on this, which may partially answer your question. If you don't mind, I'm just going to bring that up. Sorry.
Yeah, I guess in the interest of time, just to,
yeah.
you know, I think
yes.
I'm just formulating something. No, I wasn't.
Okay, sure.
So, but potentially changes, early changes in the vasculature with a new way to characterize that. So I think there is a whole vascular sort of vascular hypothesis in COPD onset in the, if you will, in the natural history of COPD. So I think we'll be mesmerizing to explore that further. So please, yeah, go ahead.
I mean, I can speak a lot on this, and thank you for bringing this up because I think it's very crucial. But in 30 seconds, the particular information we're focusing on with these measures is the so-called red pixels in this image. Maybe just by visual analogy, you'll notice that the blue pixels correspond to vasculature in the original CT, whereas these red pixels correspond to the lung parenchyma between vessels, of course, taken a certain spatial scale. And so what we are essentially measuring here with this simple measure is the proportion of such quote unquote red pixels in the lung. Mm-hmm. And so we're showing that this simple proportion is apparently discriminative. Of course, we need to go deeper, but this geometrical analysis sort of allows us to localize spatially the information that we're working with, because there's a spatial meaning to the MCI values. And again, I'm happy to discuss further offline some other time.
Okay, well, thanks, you guys. I think we'll wrap it up at that point. If anybody has micro CT images, send them to Peter, because that might be a way forward to help us do structure functional understanding of this new metric. Peter, if you stop sharing your screen, we'll turn the screen over to Rachel, who is going to give us our case presentation for the day. So Rachel, introduce yourself and take it away.
Good morning, everyone. I will first share my slides. I guess in the meantime, while we're waiting here, okay, here we go. So I'm presenting today some of the work that I wrapped up towards the end of my PhD in London. I've since moved on as a postdoc to UBC, which shows up on the schedule there. Sorry, slideshow. Just trying to flip my monitor here. There we go. Okay. So I'm presenting a case report of a patient in the London region who unfortunately experienced a severe respiratory failure. Sorry, I see the chat popping up here. I just want to make sure that it's not for me. Can everyone hear me okay? Am I muted?
You're fine.
Okay, thanks. All right, sorry. So presenting a case report here of a 17-year-old boy at the time of hospital admission, but 18-year-old at the time of research follow-up here. And so while I'm here presenting today, I do have to importantly acknowledge our research team in London, where I was very fortunate to be able to work closely with the clinical team who actually cared for the patient during his time in hospital in London, and this work has been recently published in Chest. So a brief overview of vaping or e-cigarette related lung injury. In the States, as of February, there's been close to 3,000 cases. and much less so in Canada reported as of April, but the initial report in the New England Journal here out of the Illinois and Wisconsin case studies showing essentially diffuse alveolar damage in these patients who were hospitalized. And since the initial reports and the outbreak of these hospitalizations in September of 2019, the hospitalizations have really decreased from them, but we really don't know how these patients are recovering from then. So that's where we're headed here. And so this initial case was first published in the Canadian Medical Association Journal, and I'll review quickly the clinical case here before I get into the follow-up data after hospitalization. And so this boy presented to the hospital as an outpatient and was prescribed and discharged home with an antibiotic prescription, and subsequently represented to the his community hospital about 5 days later. And the CT image shown here, if I can flip my laser pointer on, the CT images up here show a diffuse tree and bud pattern. So it's notably different from the image I showed on the previous slide of the cases in the New England Journal. About 8 days later, he was transferred to tertiary care ICU and put on ECMO, and they did a transbronchial biopsy, which is shown in the histology slide here, to confirm if there was any infection, which there was not. And in terms of treatment, he was prescribed methylprednisolone on IV for the indefinite period here up until 20 days, where he was referred to the regional transplant center, and fortunately, with a higher dose of IV steroids, he was able to recover and was eventually tapered down to a lower dose of steroids and weaned off of the veno-venous ECMO. To note, this he was a previously 17-year-old boy, and so, previously healthy 17-year-old boy with no history of any respiratory disease or any reason why he should have been more susceptible to vaping. And there was no other indication or exposure for what could have caused this type of lung disease. And so it was essentially attributed to a 5-month history of daily vaping, flavored e-liquids, as well as THC. To note, as reported in this first clinical case, the actual exposure and the actual pods were not able to be tested. And so we don't actually know at this time yet if there was any products in those liquids beyond the flavoring and the THC that could have caused this. And so showing a comparison between these two CTs now, you can see the drastic difference. The American cases essentially reported diffuse alveolar damage as well as ARDS, where the ultimate diagnosis in this patient was bronchiolitis based on the tree and bud pattern. They deemed a surgical lung biopsy to confirm the diagnosis unsafe for this patient at the time. So unfortunately, there's no confirmation of that. But so we were lucky then to work with the clinical team to follow up on this patient and follow up on his recovery after hospitalization using research hyperpolarized gas xenon MRI. And so first reviewing his follow-up lung function. And so he was clinically followed with spirometry over this 8-month period. And so in the first 3 months from hospital discharge, his lung function increased as he was started on maintenance ICS LABA and LAMA treatment. And then the specialist essentially wanted to try on a 10-day burst of steroids to see how it would improve his lung function, and it certainly did improve his lung function, but still only up to a maximum of about 55% here. At 4 months, he experienced a chest infection, was prescribed three separate courses of antibiotics, as well as added on a daily low dose of prednisone. And then by 6 to 8 months, his lung function recovered to a maximum of about 47 to 48% while he was maintaining his maintenance, or he was maintaining his treatment with ICS, LABA, LAMA, and the same low dose ICS until about 8 months, where he personally decided to stop taking his medication and reported pretty good quality of life at that point, and was not receiving a benefit so much from the treatment anymore, and decided to stop it himself. At 8 months, just to note his lung function measurements here, it did not improve with bronchodilator and was quite significantly gas trapped. It did improve a little bit with bronchodilator, but not drastically. And to note here, the imaging follow-up, there was clinical CTs acquired in terms of follow-up at the 1 month and 7 month time points. And we were able to image him with hyperpolarized xenon MRI at 4 months and 8 months. So switching into his images at 4 months, I'm showing pre-bronchodilator and post-bronchodilator. And so it's quite drastic, to be honest. We didn't know what to expect. Like I said, this was that 4 month time point where he was experiencing a chest infection. And so his ventilation defect percent, or VDP here, to quantify these regions of signal void was around 20% for both of these images. Did not improve drastically with bronchodilator as well. And so for anyone not familiar with this type of imaging, if anyone didn't see Sarah's presentation last week, the blue regions are the regions where hyperpolarized gas is filling the lungs, and then there's these regions of signal void where the xenon is not able to access. And so at the 8 month time point, there was really no improvement in those ventilation still. Ventilation defect percent was still about 20% here, and no real change again after bronchodilator, and still between this 4 and 8 month time points. And so I'll show here, just for comparison, a severe asthma as well as a moderate to severe COPD patient here, really just to compare. And it's important to note that VDP still is about 20% in both of these patients, but in contrast, they're about matched for lung function to this patient. But it's important to note the age, where this is a 59-year-old patient and this is a 71-year-old patient. So it's important to note this is an 18-year-old boy who at 8 months following hospitalization is still really, really functionally limited. And it's also important to note something from a qualitative perspective. While this is only one patient and it is a case study, the actual pattern of the ventilation abnormalities here was quite unique for anything we experienced in London. In our sort of experience in a few hundred patients with obstructive lung disease, we're very used to seeing these subsegmental wedge-shaped defects in both asthma and COPD. To note, this is an airways disease dominant COPD patient, but we're used to seeing these wedge defects that can really be spatially localized to an abnormally remodeled subsegmental airway using CT, whereas this patient's defects were almost wedged out and facing the medial portion of the lung instead. And these little circular pockets of defects were very unique. And so quantitatively, it's a little challenging to measure, but from a qualitative perspective, it was quite surprising. And so comparing CT then, CT was acquired for clinical purposes, clinical follow-up at 1 and 7 months following hospital discharge. And I'll note, I should have added the initial hospitalization CT here, but at 1 month, there still was some residual tree and bud nodules, but by the 7th month time point, the tree and bud nodules had almost completely resolved, and the CT from a qualitative structural perspective looked essentially normal. I was able to segment the airways from both of these CTs as well. And so at 1 month, the total airway count, which is just the number of airway segments or branches in the entire segmented tree here, was close to 460, which is really, really abnormal, and it's abnormal in the opposite way that we would sort of expect to see. So we're seeing more airways than usual. And as a reference here, the initial total airway count paper which to note was in older healthy never smokers, was about 220. So this is also drastically abnormal, which was essentially attributed to a mild airway dilation and possible bronchiectasis at this time point. 7 months later, our airway count came down to what is closer to normal. It's hard to say what is normal for an 18-year-old boy, but closer to what we might expect to be normal. And you can really see why if you sort of zoom in and look at this airway compared to this airway on these matched CT slices from the 2 time points. You can see the airway lumen is much more patent here and much wider compared to this one. And you can also see a thicker wall here. And it's also important to know that at 4 months, this patient reported relatively poor quality of life on the St. George's Respiratory Questionnaire. But by 8 months, his quality of life had almost completely normalized to what he would say was his normal before the hospitalization. And so he was getting ready to go back to the gym and go back to school. But it's interesting to note that while CT looks normal and he was reporting almost normal quality of life, his functional measurements, especially functional xenon MRI, were really still quite remarkably abnormal. And so we were able to acquire oscillometry at our 8-month time point. Unfortunately, due to some technical difficulties with our system, we were not able to acquire oscillometry at 4 months, and we're using the Therasis Tremoflow system. And so again, pre and post bronchodilator shown here. And for anyone with multiple breath nitrogen washout experience, we did also measure LCI at both time points, although I'm showing LCI just at 8 months, and it really did not change also between the 4 and the time months, did not improve at all. And is quite different from what the reference would be for an 18-year-old boy. The oscillometry is interesting, I suppose. It again, comparison for severe asthma and moderate to severe COPD, which are the same patients shown on a few previous slides before, to compare the xenon patterns. So there really was no improvement again with bronchodilator here for both. And there was some, the R5 was elevated slightly from reference. The reference lines are shown in white, whereas reactance was definitely more negative at the lower frequency, and the resonant frequency was certainly pushed over compared to severe asthma, where you would typically expect to see that the R5 improve after bronchodilator, as well as X5, where as COPD shown post bronchodilator anyways here, there was really no frequency dependence in the resistance at all. And so this pattern from a qualitative perspective then seems to be somewhere in between these two patients. And again, to note, this is an 18-year-old boy who is really, we're sort of question about how well he will be able to recover his lung function. So just to wrap everything up here and bring all the physiology together, I hopefully stayed on time to leave a lot of room for discussion here. This image shows a posterior view of the 8-month time point with the xenon image rendered in 3D and co-registered to the CT and the airway tree to try to highlight some of these regional structure-function relationships and what we can pull out of these physiological measurements from our R5, R5 minus 20, X5, as well as our lung clearance index. And so what I really want to highlight again is this unique pattern, this sort of hollowed out defect here, which you can localize to these regional airways. And so it's definitely challenging to make a final statement on this case, but we're hoping this case can provide some pilot data and provide some justification to longitudinally follow up these patients who experience vaping-related lung injury, and to dive deeper into the pathophysiology. And so I'll finish there and thank our clinical team who worked with this patient, the team at Robarts and Western in London. We normally have a nice group photo, but unfortunately we are not so much allowed to do that now. So I'll finish there, and I'm happy to take any questions.
Great, Much for a spectacular talk. I'm just going to tell everybody I've made an executive decision. We will allow the seminar to go 10 minutes over time because I don't want to rush either Alex's discussion or the next presentation of the equine oscillometer. For those of you who can't stay past 9 o'clock, we will post the recorded session minus those segments that will be cut out by request of presenter within a week on the website I showed you at the beginning of the talk. Okay, Alex, over to you.
Yep, thanks. So we are, yeah, I think we were running a bit late, so I said I'd try to be brief, but thanks for the extra time. I think, can you hear me okay?
Yes.
Yeah, okay. Thanks. So I want to say thank you, Rachel, for a clear, concise presentation of your work. And I want to say thanks to Ron for inviting me to participate in the seminar. So my background is briefly mathematics and interdisciplinary research. I met Ron through my PhD supervisor, Selman Siddiqui, at the ERS in Milan, 2017. Currently a postdoctoral research fellow at the University of Michigan. So I work on CT image analysis and association with respiratory disease. So I just want to try and give a brief summary from my perspective on the paper and then see what you think to that, Rachel. So this was as a case study in an older teenage boy. You were looking at e-cigarette related disease and lung damage. The focus of the work was really on imaging, I think CT and MRI, and I felt like perhaps impulse oscillometry played a relatively peripheral role. And I do have like a question or two on that. And I think the main kind of conclusions from your work were that though he reported a higher quality of life and some improved PFT performance, which is his FEV1, there was still abnormal ventilation heterogeneity at 4 months and 8 months, so at 8 months. And you showed this with the multiple breath oscillate. The LCI didn't change. You showed it with the oscillometry with the final time point. The R5 minus 19 was still significantly higher than what is healthy. Yeah, and in the imaging, so with the xenon gas, you can see the ventilation was still abnormal. So is that correct? Or do you want to clarify anything based on that summary?
Everything's correct, yeah.
Yep. Okay. So one question. So I think, did you cover the fact that there was iOS data at 8 months, but not at 4 months?
I did, yes. We had an equipment malfunction around the 4-month time point and just weren't able to acquire it at that time.
Yeah, so that's unfortunate. I wanted to ask, so given the relatively peripheral role, what would you say was the value of using impulse oscillometry in this study? So was it, say, complementary to multiple breath washout for looking at the ventilation heterogeneity?
It was complementary to the imaging, I would say. Our group has done a lot of work comparing to the ventilation abnormalities and the ventilation heterogeneity that we see in the hyperpolarized gas images and try to help us understand what's maybe driving that ventilation heterogeneity, if it's a parenchymal stiffness or, you know, as with the diagnosis of bronchiolitis, expect to be more small airways. Resistance issue, again, with this single case, it's definitely challenging to comment. And as we've heard a lot today and in the session 2 weeks ago, it's hard to actually localize that. And so if we can use the imaging and the oscillometry in combination to start to localize that.
Okay, cool, thanks. I wanted to ask, so you've done this, so you've checked the MRI at 4 months and 8 months. Are there additional time points planned for this subject?
Yeah, hopefully. There was an additional time point to be attained around June. Hopefully it would have been about a 1-year follow-up. And because he stopped taking all of his medication to sort of follow up and actually use the imaging to guide his treatment and investigate whether he was responding to some different treatments. They were considering maybe an antibiotic therapy, chronic antibiotic therapy, because he clearly was not receiving any benefit from the steroid treatment anymore. And so longitudinally, hopefully, to follow up and use the imaging as a tool to understand his treatment response. That being said, with the research lockdowns, with COVID, I think there's concern about him being especially susceptible to developing any severe kind of disease from COVID. So I think that will be postponed, unfortunately, but I believe he's still, I think it's still, of course, receiving a change of treatment at this time as they've moved on from London. I'm not entirely sure involved in the case per se anymore, but hopefully in the near future.
Yeah,
I
I
was
think
just
that'd be,
wondering, Alex, if you would be able to speculate a little bit based on the work that you've done. Could you localize the site of pathology? Going way out on a limb with an N of 1, I recognize, but how would you put the data together yourself?
how would I put, well, first of all, I would, because I think these were single scans. Were they at expiration or inspiration?
They were at inspiration, they were clinical scans. And so we talked about trying to do an additional inspiratory-expiratory paired research image at the 8 point, but he had 4 CTs during his time in hospital and then 2 follow-up clinical CTs. So we did not want to expose, and actually many of his CTs were at the community hospital. So the radiation dose was less than desirable.
Okay, I think just to answer your question, Ron, so in my PhD, I used inspiration and expiration scans and image registration to look at the change in, say, Hansfield units, so the function from the 2 scans at TLC and FOC. So what I'd use, and what I developed as an algorithm looking at the gradients of lung function going, say, anterior to posterior or inferior to superior. And that's something that I definitely say apply in this situation. If that makes sense.
Yeah, we certainly were hoping to, especially with the known diagnosis of bronchiolitis, if there was any gas trapping on expiratory CT, but it just wasn't appropriate here.
Okay, I do have just
a general question. Are there other people out in the audience who have experience with vaping victims clinically, and have you had a chance to study their physiology, as challenging as it is in the current pandemic context?
I wanted to ask a question meanwhile. Smita Pakhale here. Thank you, Rachel, for presenting. I wanted to ask, can you hear me?
Yep.
I can hear you.
I wanted to ask if you know the history, because we know from our population that Carly presented our data on the smoking and substance use and vaping. What is most common, one thing is most common is the recurrence. And do you know if the boy did restart vaping or smoking later during that 8 months period?
No, he was still completely abstaining from any smoking, vaping, anything. Yeah.
Okay, I think we will move on at this point because we are 5 minutes before the hour. And in usual style, I am running late. I'd like to turn over the screen and the podium to Stefano from Italy.
Yeah,
Stefano.
good morning. Can you hear me?
Yep, just fine.
Okay, thank you. I share the screen. Okay. Okay, can everyone see?
Yes, we have full screen.
Okay, thank you. So good morning, everyone. My name is Stefano Paganini from Politecnico di Milano University. And today I'm going to talk about what was my master thesis about the design and development of a novel device for evaluating lung function in horses by oscillometry. If we compare horses to human beings, we can see how at the same breathing frequency, horses present values of tidal volume, total lung capacity, and experimental ventilation more than 10 times greater than humans. And this difference grows bigger during exercise. This is the reason why respiratory diseases in this species are so critical, because they strongly influence their performances. Equine asthma, also known as HIVS, is respiratory pathology that affects from 10 to 15% of adult horses in temperate climates in its severe form, and has symptoms that can be compared to the ones observed in human chronic asthma. And it is related to the presence of organic dust and mold in hay and poorly ventilated areas. However, the symptoms are not evident in horses with only mild obstructions that may show only intolerance to physical exercise. Therefore, a correct diagnosis of this disease is quite difficult. So the common diagnostic methods are based on the analysis of the clinical history of the subject coupled with bronchoalveolar lavage cytology. Also, pulmonary function tests may give objective information on the mechanical properties of the airways of these animals. However, all these techniques present drawbacks as they may be invasive and they may require collaboration from the animal that is quite unrealistic. Therefore, they may lead to sedation. It has been proved to alter the mechanical properties of the respiratory system of the animals. And moreover, none of these techniques alone is considered sufficiently accurate. One promising alternative was found in oscillometry, as during the years, few studies were performed on both healthy and pathologic horses, using either monofrequency sinusoids or impulses as stimulus, and obtaining similar results if compared to the ones obtained in humans, if we consider the shape of resistance and reactance curves in function of the frequency of the stimulus. However, all the setups used in these studies were built only rescaling setups used in humans and based on loudspeakers or air compressors, and therefore they resulted cumbersome, complex, and expensive. And they added that space and resistive load onto the respiratory system of the animals. This is the reason, basically, why oscillometry is still not used in clinical practice. In this context, the aim of our work was to design, develop, and validate a new portable device that was able to exploit oscillometry to assess the mechanical properties of the airways on the horses. The final goal of this work is the construction of a small, easy-to-use device that can be easily introduced in clinical practice. To do so, the device has to respect some requirements. It has to impose the desired pressure oscillation onto the animal's breathing without interfere with it. It has to be well tolerated by the animal. It has to accurately measure impedance values, and it has to be compact, portable, and easy to use, and suitable also for field tests. It appears clear how these requirements cannot be satisfied with the previous approaches based on loudspeakers as pressure oscillation generator. And therefore, we adopted a new approach based on the motor and the propeller placed directly at the airways opening. This allows to drastically reduce the device's dimensions and therefore improving its portability and minimizing the space and resistive load applied. We can see in the figure the architecture of the device. The air compression unit is formed by the motor and the propeller encapsulated in a specifically designed and 3D printed case. It has to generate the pressure oscillation and allow the horse to breathe through it. Then the oscillations are delivered to the horse by a face mask that is visible in the picture on the right. Between the inlet of the mask and the air compression unit, the sensing unit is present and is formed by a pneumotachograph and by differential pressure transducers that record the airflow breathed by the animal and the level of pressure at the inlet of the mask. The whole device is then controlled by a control unit that has different tasks, as it has to constantly adjust the velocity of the motor in order to correctly generate the pressure waves. It has to sample data from the sensing element, and it has to exchange data with the laptop. The device was first validated in vitro with the aim of assessing its ability in the correct generation of pressure waves in terms of shape and frequency content, and then to evaluate the accuracy of the impedance measurement. To do so, the device was connected to a test object with known mechanical properties, and impedance measurements was performed at each integer frequency from 1 to 6 Hertz. The quality of the pressure wave was assessed by spectral analysis for what regards the frequency content, while the shape was measured using the pressure shape index, that is an index that measured the difference between the pressure wave produced and an ideal sinusoid. And it was the wave produced is considered acceptable if this index is below 0.1. Regarding the impedance measurement, we measured the maximum error in reactance and resistance computed with the device and the theoretical ones of the model. And both the maximum error in resistance and in reactance were considered acceptable for this prototype. The device was then used in a clinical study at the University of Montreal with the aim of assessing its abilities as a classifier in the discrimination between asthmatic from healthy horses by means of the mechanical parameters estimation. A population of 8 healthy horses and 10 pathologic horses was studied. The protocol was composed by a measurement with our device exploiting all frequencies from 1 to 7 Hertz with a step of 0.5 Hertz. And it was followed by esophageal manometry. With esophageal manometry and the analysis of the clinical history of the animals, the clinician could divide the horses in 3 groups. The group of healthy controlled horses, the group of asthmatic horses in remission, and the group of horses in exacerbation. In the figure, we can see the results of the measurement expressed as the mean values of resistance and reactance for each group in function of the frequency of the stimulus. We can notice how frequencies below 2.5 Hertz were excluded. This is because the frequency of the stimulus was too close to the breathing frequency of the animal, and therefore the spontaneous breathing interfered with the generation of the correct pressure wave, and the resulting measurement was too noisy to be considered reliable. If we observe the resistance graph, we cannot notice a clear separation between the 3 groups. Instead, if we look at the reactance, we can see that the 3 groups are clearly separated. The performances of the classifier are shown using a receiving operating characteristic curve. We can see that if we consider the discrimination between the control group and the exacerbation group, the values of the area under the curve are extremely high for each of the parameters considered, that are the reactance at 3, 5, and 7 Hertz. And that if we choose a threshold value for the reactance at 5 Hertz equal to 0.1 centimeters of water per second over liter, the sensitivity and specificity of the classifier are equal to 90%. Even more interesting is the result if we compare the control group with the remission one. And in fact, we can see that the values of the area under the curve are still extremely high if we consider the reactance at 5 and 7 Hertz. And that if we choose a threshold equal to 0.2 centimeters of water per second over liter for the reactance at 5 Hertz, both sensitivity and specificity of the classifier are equal to 88%. In conclusion, we developed a device that it's portable, easy to use, and that is able to measure in a non-invasive way the mechanical properties of the airways of horses, and is able to discriminate between control group and pathologic horses, both in exacerbation and remission phase, thus proving the potential of this device in clinical practice. And with this, I thank you for your attention.
Stefano, that was great. In the abrupt transition between talks, I failed to thank both Rachel and Alex for the previous talk. And Stefano, I should have allowed you or asked you to introduce yourself to put this into context and also tell us who your collaborators are, because this is between Milan and here in Quebec. And then finally, Michela, I'll let you take over the screen after that.
Thank you.
Okay.
Stefano, just give us a little background and introduce yourself, please.
Oh, I just graduated in Politecnico di Milano. I work with Professor Raffaele Dellacà on this project, and also with Professor Jean-Pierre Lavoie in Montreal, because I spent some time in there, and also with Professor Ferrucci and Luca Stucchi for this project, and we are currently working on it. Also, if we had to stop for the COVID situation, but we hope to begin to work on it soon.
Okay, thank you. So, Michela, can you help us non-veterinarians understand what's going on and the impact on this on the practice? Thank you.
So, good morning, everyone. Thank you, Stefano, for the presentation, and thank you, Ron, for inviting me. Briefly, I'm a veterinarian and a researcher at the Department of Veterinary Medicine in Turin. I've been working with the iOS during my PhD, which I did in the lab of Jean-Pierre Lavoie in Montreal. And concerning your presentation, Stefano, congratulations. It was very nice to hear this good news from you. Finally, we found some device that can differentiate, hopefully, horses with asthma in remission from controls. I have a lot of questions for you, but I would just pick up the more maybe significant for me. And I start from a technical question. Maybe it's very easy, but I don't know the answer. I've noticed that you have the maximal error that you have with your device when using the object with the known mechanical properties.
Okay.
The maximum, there. The maximum error in the reactance is threefold the one that you get for the resistance. Is this expected? Is this due to the property of the object that you tested, or is it something that you did not expect?
No, it actually is something that we did expect a bit because it is related to the fact that the values of the model were not tested with a gold standard, but they were calculated mathematically. They are theoretical values, and while it's easier to calculate correct resistance values, in this case was more difficult to calculate an exact reactance value, because we would have to consider each small physical piece of the model, and it's not possible to calculate with so much precisely each component of the model. Therefore, we should, of course, we should measure the real values of the model with a gold standard, but we didn't have one, and so we calculated them theoretically.
Okay, so there's a reason for this.
Yeah.
And also, it's meaningful for me that the difference that you notice between horses with asthma, even in remission and control, is mainly detected with reactance values.
Okay.
This is what I would expect. Could you differentiate inspiratory versus expiratory values or not?
Yes, actually, we already did that. I mean, it's not reporting in here, but with our device, we can separate the expiratory from the inspiratory values.
Okay. And do you know in which respiratory phase do you have the greatest differences between?
Yeah. In expiratory values, we observe the greatest difference.
During inspiration, sorry?
Expiration.
Okay. And do you have the data from your lung function test made with the manometry? I mean, for resistance and elastance, do you have them?
Yeah, I don't have in the presentation. I don't have them in presentation, but I looked at them.
Can you recall if there was a difference between horses in remission and controls for the elastance values?
Yes, for example, I recall that elastance values, compliance, the pressure difference. Yeah, that was a difference. In fact, also with standard lung function, it is clearly possible to discriminate between healthy horses and asthmatic horses in remission and in exacerbation. But I think that the advantage of using our device, it's first of all the non-invasiveness of the procedure, and then also the fact that your procedure of the insertion of the catheter in the respiratory system of the horse, it has to be performed by a trained clinician, and also the horse has to be, I think, used to it. I asked Professor Lavoie if he wants to add something to this, because it's not really my field of knowledge. But I think that with our device, horses got used to it very quickly. And so I think that this is the main advantage of using our device instead of the standard lung function.
Do I have time for one last question?
Yeah, sure, go ahead.
I'm curious, did the horse you tested, were the horses similar in size and age?
Yes, especially in size, they were kind of all very similar. Yes.
So would you expect a different sizes
size of the horse? Yeah. I think that different size of the horses will influence the respiratory parameters, and so it would be very interesting to perform larger studies with a greater number of horses and try to extract some reference equation for the parameters.
Thank you. I think I'm done.
Okay, well, thank you, Michela and Stefano. JP, if you're there, do you have anything more to add before we end the meeting to the discussion?
Well, actually, I think Stefano and Michela really covered most of the topic. I just want to maybe mention that it is a great need in clinical practice. Currently, we do not have a mean to accurately detect airway obstruction in horses, so that would be a really leap forward if this device make it to the market. So, and obviously, determining normal values will be a challenge as well, because from the data we have so far, race horses or really high performance horses might have values which are quite different than our standard healthy horse that we use in research.
Okay, great. Well, unless there's one last question from the floor regarding the equine oscillometer.
Yeah, I just got a quick question. I looked at the horses in remission and the control and the ones that were having exacerbations, and there are no resonant frequencies. And I'm curious, what in a typical healthy horse, maybe a non-race horse, what's a resonant frequency?
It should be around 2 hertz.
2 hertz. Okay,
Yeah.
and then if they're not racing, what's a typical spontaneous breathing rate in a horse?
I have no idea, sincerely.
Yeah, I just it's interesting. There's so much inertial load at relatively low frequencies. So
yeah, that is the reason why we try to use also frequencies like 1 and 2 hertz in the device.
Okay.
Also try to calculate AX as Ron was suggesting, but often we couldn't get a meaningful resonance frequency.
Yeah.
Okay. Yeah.
Okay, and if I understand correctly, you're applying a single frequency at a time and working your way up. It's not a so those should be of high enough fidelity that you're able to partition, as you were discussing earlier, into inspiratory expiratory phase. So you should be able to do nice intra-breath analyses.
Yeah. Sorry, okay.
We look forward to a follow-up of the data that you're going to
I hope to continue working on this. Yeah, of course.
Well, congratulations on a great innovation, a fabulous talk. I want to thank all of the presenters once again, Carly and Chung Wei, David and Jeff, Peter, Raul, Rachel, Alex, and of course, Stefano and Michela. And I'll end the meeting at this point. Remember, the recording will be available. So if people signed out early, I'll remind them over the internet, and look out for future emails in the coming week. We have a 2-week session, as I spoke at the beginning, which will be a potpourri of topics to be announced, and then the final session in a month's time, where we'll talk about the COVID ventilators and maybe have a roundtable discussion on pulmonary function in the COVID era. So thanks everybody for your participation and interest, and I look forward to seeing all of you in 2 weeks. And again, thank you to our industrial and partners. I will certainly be talking to you in the coming weeks about hopefully getting this series published. Okay,